This is a case of lamellar cataract in a 4-year-old girl, and she has a vision of hand movements close to face. She fixates very well. Her parents don't have any kind of opacity, and her B scan was normal, and we did the biometry as well. Her the keratometry was 41 and the axial length was 21.56. So we are going to implant a lens of 24.5 Baptist. So what you're going to make is 2 MAR incisions. We are going to use the viscoelastic to make the anterior chamber deep. This viscoelastic has the property of dilating as well as deepening the anterior chamber. So it's a dial property. So it makes our things easier.
And is that viscose or is that a cohesive or dispersive?
This is a cohesive one. This is a viscote. So this is a co-eliminator which is available in this microscope. It makes things easier to do the rhexis. So you can see the central nucleus. So I'm going to make a small opening here. So this is the engrasping vitreoretinal forceps what we are trying to use here.
There's a question in the audience.
Yes, please.
As we know that the viscose has a property for coating the endothelium more than forming the anterior chamber.
Yeah.
More form caused by the hyalon, that is hyaluronic acid.
Yeah.
So why you using viscose for this case?
Exactly. We can use one of that. So it's not that we are using too much of phaco power in this case. So any one of that can be used. So this was one of the available things. So I used it. So in the initial part of the training, if somebody wants to use Viscomet, that's fine too in this kind of situation. So this, I need to make the incision a little bit bigger. Later time, you can implant the lens from the same incision if you want. So that's the advantage of that. You can faintly see the edges here.
We have a pretty good visualization here in the classroom.
Yeah.
How is the consistency of the capsule? It looks pretty soft. It doesn't look like a friable or a dense.
It's quite okay. It's totally different from the infantile cataract where it will be very friable. So if you aim at the size of the nucleus, you will go a little bit bigger than that. That's what happens usually. So you can see the last part is still there. So I need to take it out. So in the initial part of the training, it's better to go in and come out as much as you want. You want this rhexis to be clear, round and regular. Whether the hydro procedure is required. In a kid, probably it's not required because it may not make anything better for you. In an adult, probably it's required.
And now you're just using bimanual, and this seems fairly soft. Is that correct, sir?
It's usually a very soft cataract. I try to aspirate the peripheral part first and then come to the center.
Yes, sir.
Reason is that the nucleus acts as a tamponade against the posterior capsule. So that makes the life a bit easier. But sometimes the nucleus can just pop up. It's just like a lollipop. It can just come up. So it's okay even if it comes up. But as much as possible, if you can avoid that, that's fine. So right now you can see that nucleus is coming in the way. So you can push it back and go for the other cortical matter, or you can just aspirate it. It's the most important and probably the hardest part of the pediatric cataract. Otherwise, it's quite soft.
And do we know the etiology or the cause of this cataract? Was
Yeah,
it
this particular case, we tried to look at many of the possible etiology. We examined. We really don't know the etiology in this particular case. So around 40 to 50% of the developmental cataract, we don't know the etiology in kids. Next generation sequencing for the genetic test, if you do it, probably you might get, but whatever clinically possible we have done in this case, we did not see any physical abnormality in the face or systemic examination. But most of these cases, what we see, they are idiopathic. We don't have any specific cause in this kind of children. Unilateral, it's a different ball game. So
Yeah.
their etiology is a little bit different.
right?
So bilateral means you think of systemic disease. So we have to think of more of syndromic things in a bilateral, but
Yes.
still, in spite of all that, most of these cases are idiopathic. So this is taking a little bit long because we have increased the size due to the difficulties what we had in the anterior capsular axis. So whatever the depth you have, you can't have the complete depth with this larger incision. So it will take some time. So you have to be patient. Then you can give a better outcome for these patients.
And sir,
Okay.
I know every patient is different, but
Yes.
back home in your practice,
Yes.
what age do you do a primary vitrectomy capsulotomy or able to get them to do a YAG capsulotomy?
Typical textbook says we should not do primary posterior capsulotomy after 6 years of age. What we have seen in our country is even after 8 years, 9 years, they develop this capsular opacity. So I do it till 8 years of age or so.
Is it just the posterior capsule that's opacifying, or is it also the anterior hyaloid?
It's even anterior hyaloid. We did a study just doing PPC as well as without anterior vitrectomy. Still, we had opacification in these kids. So I think it's a combination of both. The cells migrate from the vitreous. It
Yes.
acts as a scaffold and it comes. Right now, what I'm doing is I'm polishing the anterior capsule, the posterior part of the anterior capsule. There are tiny epithelial cells you
No,
can
we're
see.
able to see it very clearly,
Yeah.
sir. Do you think this helps with both PCO and late decentration? Do you think removing the epithelial cells help with decentration or no?
It helps to prevent the posterior capsular opacification. These lens epithelial cells are like stem cells. They can proliferate over a period of time and they can come behind your capsule, and we have to clear it as much as possible within the limitation. I'm trying to remove, see in this area, if you see, these are the cells. It takes more time, but I think it's worth it removing all of these cells as much as possible. Just a few cells are left. I'm a little bit persistent about that, so I do it in every case. I think it helps. We'll implant the lens now. Yes, 24.5. We are going to put a hydrophobic single piece lens. Yeah, I will in this case, because the capsular axis forceps does not have a vertical dip. So if it is there, I'll be happy to do a posterior capsular axis.
So far, no questions. When you're doing your posterior capsulotomy, capsular anterior vitrectomy,
Yeah.
how big an opening do you want for the
Yeah.
posterior capsulorhexis.
Yeah.
And how deep do you go? Where does your probe go relative to the posterior capsule?
Yes. With regards to the size, I used to aim 2.5 millimeter earlier, but what we thought down the line is that they get 5 most over a period of time. So now I aim somewhere between 3.5 to 4 millimeter, around 1.5 millimeter less than the anterior capsulorhexis size. How deep? Just behind the posterior capsule. I don't do a very deep anterior vitrectomy. What we need to cut is the posterior hyaloid face. You need to cut. You need to be at the surface of the posterior capsule. Don't have to go behind. What I usually tell my fellows is that when you inject viscoelastic, the posterior capsule bows down. It becomes convex. Just make it flat after the vitrectomy. So the first target is just to push this guy in, and then you can just nudge it in. No need to rotate too much in pediatric cataract. Do I go pars plana or do I go anterior vitrectomy? Both are fine. My personal preference is through this port. It makes things easier because I do not have one more incision here. I go with one incision. We are at the linear 3000 cut, right? So my cut rate is varies between 1000 to 3000. So this is a linear cut, which makes my life easier. I have total control to go between 1000 to 3000. What I'm trying to go here, just this is an important step. I'm going behind this anti-capsule, trying to go, press the IOL there, and then the probe comes here, and that way the eyeball moves a little bit, the lens moves a little bit, and then I start the capsulorhexis. You can see that opening there. So this is my initial opening. So I go low cut rate, and then as I go inside, I increase the cut rate. Now I'm close to 3000.
And again, you don't feel a need to go very far deep into the
Yeah,
vitreous.
look at the level. I'm just behind the capsule. I used to do very deep. Then what it happens is that the eye becomes so soft, you can't even implant a lens. So it's not even required to disturb the vitreous so much. So at this point of time, I'm done with the left part of this capsule axis.
Yes, sir.
You can see I'm stopping here for a bit. I'm turning it this. You can see this is a finger movement, not an elbow movement. This is very important. Sometimes in the initial part, this machine is so good that it just shaves off this posterior capsulorhexis. Again, I do not have any financial interest, but it makes my life very easy. Again, I'm stopping a little bit here, and then my fingers rotate on this direction. Yeah, now you can see I'm almost reaching the end point. When I'm at 3000 here, I'm just at 3000 here. Your posterior capsule should not flap because there should not be any capsule or strands coming in between. So this is almost the end of that. So when you come out, try the centration of this lens. So this is the last time you're in the antechamber. When I come out, what I do is I inject air with the other hand, and then I suture. So again, viscoelastic, when you put at this point of time, it will disturb your, you have to go again. So that one step less. Some point you're going to take out this suture. just make sure that you are not full thickness. I'm going partial thickness here.
Oh, partial thickness. Okay.
Reason for that is I'm going to take it out one day. When you take it out, I don't want the infection from cornea to go into the intracameral area and cause infection. But you need to be very, very careful that you are partial thickness, not full thickness. Very, very important.
But what sutures do you use in a child? Do you use absorbable? Do you use what do you prefer to use?
Yeah. Again, Bangladesh is almost similar to India. In India, we use 10-0 nylon. Reason is chances of infection. When I was in US for the fellowship, there 90% of the patients get Vicryl suture. So preference is definitely 10-0 nylon.
Thank you, sir.
Thank you.